started. Why is hormone testing performed? I thought I would leave this question to the reasons provided by clinicians on requisition forms. One of the most common reasons is fertility screen or patients who plan on pregnancy, patients already on assisted reproductive treatment. Another common cause is polycystic ovary syndrome, hirsutism, acne, obesity, dysmenorrhea, amenorrhea, or abnormal uterine bleeding. And another common cause that I've highlighted is menopause, perimenopause, query menopause, and symptoms like hot flushes. And hormone testing can also be performed as part of an endocrine workup. What are reproductive hormones? Reproductive hormones are hormones of the hypothalamic pituitary gonadal axis as well as the adrenal glands, and they are crucial for reproductive function or normal physiology. Normally, the concentration of these hormones are well characterized. However, when there's dysfunction, the laboratory can play a role by measuring these hormones and provide information regarding the underlying pathology and guide appropriate treatment. This is important as it will influence fertility, pregnancy, puberty, and just the general well-being of the patient. The key reproductive hormones that we'll focus on is testosterone, estradiol, progesterone, follicle-stimulating hormone, as well as luteinizing hormone that I'll refer to as FSH and LH. Other hormones include sex hormone-binding globulin, prolactin, thyroid function tests, dehydroepiandrosterone sulfate and ristenedione, 17-hydroxyprogesterone, beta-human chorionic gonadotropin, as well as anti-Mullerian hormone. To be able to understand and interpret these hormones, it's important to understand the physiology behind them. Let's just run through hormonal regulation in males. The gonadotropin-releasing hormone from the hypothalamus will stimulate the secretion of FSH and LH from the anterior pituitary gland. The release of GnRH is episodic, and this results in a pulsatile secretion that occurs around every 90 minutes. In males, LH will stimulate testosterone production in the Leydig cells in the testes. Some of the testosterone can be converted to estradiol by aromatase, and testosterone can also be further metabolized to dihydrotestosterone by 5-alpha reductase. FSH together with testosterone stimulates spermatogenesis in the Satoshi cells, and inhibin provides a negative feedback mechanism. Similarly, in females, gonadotropin-releasing hormone will stimulate secretion of FSH and LH. LH will act on your theca cells in the ovary, while FSH will act on your granulosa cells in the ovary. And these FSH will modulate aromatase, which converts testosterone to estradiol. The sex steroids are all synthesized from cholesterol, which is why I included this diagram. So they all have a similar structure, and basically progesterone is the precursor of estrogens and androgens. Estradiol and progesterone will provide a negative feedback, and estradiol can also provide a positive feedback, which is important for the LH surge in the menstrual cycle that we'll see in the next slide. In females, estrogen secretion by the ovaries is stimulated primarily by FSH during the first part of the menstrual cycle. And as the estrogen concentration in the blood increases, the FSH secretion will decrease until estrogen results in a positive feedback mechanism, causing the LH surge, which is important for ovulation to take place, as well as development of the corpus luteum. as the estrogen and progesterone concentration increases, this will provide negative feedback and inhibit the secretion of FSH and LH. If conception does not occur, the decreasing concentration of both estrogen and progesterone from the regressing corpus luteum will trigger menstruation and the release of LH and FSH, which will result in follicle maturation for the next cycle to take place. Let's look at the clinical utility of measured hormones. So we'll go through each hormone individually. First of all, testosterone. Testosterone is responsible for the development of secondary sexual characteristics in males, spermatogenesis, musculoskeletal growth, as well as erythropoiesis, and it also maintains the function of the prostate and the seminal vesicles. Testosterone measurement can aid in the differential diagnosis of disorders of the hypothalamic pituitary gonadal axis and can also be measured to monitor treatment, both anti-androgen treatment and testosterone replacement therapy. There are a number of causes for increased or decreased testosterone levels. Exogenous testosterone use as well as androgen-secreting tumors can increase testosterone, while decreased testosterone levels can be seen in normal aging. Certain medication like dexamethasone, digoxin, spironolactone, chemotherapy, as well as liver cirrhosis. Testosterone also has a role to play in females. In females, it's synthesized by the ovaries and the adrenal glands. It maintains bone and skeletal muscle mass and function, and is also important for vulvovaginal health. The clinical utility is mainly for states of hyperandrogenism, for example, polycystic ovary syndrome, or in androgen-producing tumors. In androgen-producing tumors, the testosterone concentration is usually markedly increased, greater than 9 millimoles per liter, and usually in PCOS it will only be mildly increased. It's important to note that testosterone circulates in blood in different forms. Most of the testosterone is bound to sex hormone binding globulin. Small majority is also bound to albumin, and then a small percentage is free, and this is the biologically active form. When we talk about bioavailable testosterone, it includes both albumin bound, because it's weakly bound, so it is mildly active, as well as our free testosterone. So especially in females, the free and bioavailable testosterone can be used to provide a better evaluation of the androgen status. It's only in pregnancy that the free testosterone calculation can't be used because of the alterations of your sex hormone binding globulin and albumin concentration. The free androgen index is also useful to estimate free testosterone in women with hirsutism or hyperandrogenism. In male patients where the testosterone concentration is borderline or low, free testosterone can be useful, and also in patients where clinical symptoms are present but the total testosterone is normal, the free testosterone can provide more information. This is an example of a laboratory report of a 51-year-old female where the free testosterone is increased, and then a differential diagnosis will be provided as either adrenal or ovarian origin. Obesity is an interesting phenomenon where the sex hormone binding globulin can be decreased as the body mass increases, and this can also result in decreased total testosterone as well as free testosterone. Looking at sex hormone binding globulin, it's produced mainly in the liver. It's the transport protein for testosterone, estradiol, as well as other steroids. Most of the binding sites are occupied by testosterone, and it binds to testosterone with a very high affinity. Estradiol also binds to sex hormone binding globulin, but it has about a 5 times lower affinity. The clinical utility is conditions that alter your sex hormone binding globulin and androgen levels, and when the total testosterone is in the borderline range. So this table demonstrates causes of increased and decreased sex hormone binding globulin, and this should always be kept in mind when interpreting total and free testosterone. Next, we have estradiol. It's mainly produced by the ovaries and the placenta during pregnancy. The adrenal gland and testes can also produce a very small amount. It regulates the menstrual cycle and prepares the uterus for implantation. So levels vary throughout the menstrual cycle, and that's why it's important to note in which part of the cycle the patient is to be able to interpret it correctly. It's responsible for secondary female characteristics and circulating blood bound to mainly sex hormone binding globulin and also albumin to a lesser degree. It's required for maturation of sperm in males. When we talk about estrogen and estradiol, we often use the term interchangeably, but we refer to estradiol because it is the primary form of estrogen in the body and is also the most potent. The clinical utility of estradiol is also to investigate disorders of the hypothalamic pituitary gonadal axis, such as gynecomastia, because delayed or precocious puberty, infertility, amenorrhea, and menopause. Levels are also often measured in patients on fertility treatment to determine their follicular status. Next, we have progesterone, which is secreted by the corpus luteum and by the placenta. It maintains the uterine lining for implantation of the fertilized ovum. If no implantation occurs, then the corpus luteum will degenerate and the progesterone levels will decrease. Levels increase during pregnancy to inhibit myometrium contraction, and often progesterone is measured together with beta-HCG. But the clinical utility is often for fertility workup to detect ovulation, especially day 21 progesterone, and also assess the luteal phase for luteal phase defects which can affect ovulation and fertility. Increasing levels are indicative of viable pregnancy. This is a table that summarizes some of the fertility hormone testing in women. And as we can see there, progesterone is often measured on day 21 in a regular cycle, and values greater than 30 nanomoles per liter will confirm ovulation, although these levels, different sources may give slightly different values. This is an example of the laboratory report of a 38-year-old female, where we can see the progesterone concentration is 72.1 nanomoles per liter. It was indicated that the patient is 5 to 6 weeks pregnant, which is in keeping with the first trimester. In early pregnancy, progesterone is produced by the corpus luteum, and this is in response to the beta-HCG, and then later on in pregnancy, the placenta produces the progesterone. In women, FSH will stimulate biosynthesis and secretion of estrogens and ovulation, while in males it acts on the Sertoli cells to support spermatogenesis. In menopause, the FSH levels will increase in response to decreased ovarian estrogen production. FSH together with LH can also be used to determine if a low estrogen or testosterone is due to pituitary failure or due to gonadal failure. Luteinizing hormone secretion is regulated by estrogen in women and testosterone in men. It stimulates follicle maturation, rupture, and ovulation in women, and it stimulates the development and functional activity of the Leydig cells, which is important for testosterone secretion in men. So the clinical utility of both FSH and LH is once again to evaluate disorders of the hypothalamic pituitary gonadal axis, for example, infertility, menopause, amenorrhea, etc. Just to mention, often the ratio is used in PCOS, but we'll get to that in the next few slides. This is another example of a report for a 57-year-old male where the total testosterone, sex hormone binding globulin, and the free testosterone was requested. As we can see, the total as well as the free testosterone value is decreased. And important to note is that it's ideal to do the testosterone measurement early in the morning to rule out the circadian variation. And also that when concentration is decreased, to also repeat the measurement to confirm the value, that it is indeed low. And here we can see in the comment section, if the LH and FSH is increased for this patient, it indicates a testicular defect. And if the LH or FSH is normal or decreased, it indicates a hypothalamic or pituitary defect higher up. Let's look at some of the other hormones. Prolactin stimulates and sustains postpartum lactation. It's routinely requested in the fertility workup for both males and females because it inhibits gonadotropin releasing hormone and will decrease LH and FSH. Elevated levels can result in oligomenorrhea and amenorrhea, as well as impotence and oligospermia in male. So there's a number of causes for increased prolactin. One of them is a prolactin-producing tumor, drugs, emotional stress, as well as physical exercise, and a high-protein diet can also increase the prolactin concentration. Prolactin secretion is mainly controlled through suppression by dopamine. So there's no stimulating factor, it's mostly an inhibitory regulation. Here we have an example of a laboratory report for a 49-year-old male. The prolactin is slightly increased, and usually the recommendation is to repeat the test after 2 to 4 weeks under resting conditions, as it might be due to stress, exercise, etc. Here we have a laboratory report for a 49-year-old male. So the prolactin concentration is 75. And usually when prolactin is within this range, it's not high enough to typically be caused by a tumor, although it can't be excluded. But common causes are listed here. So drugs include metoclopramide, antipsychotics like haloperidol we often see as a cause for elevated prolactin. And then other causes include pregnancy, hypothyroidism. So hypothyroidism is interesting, where the increased thyrotropin releasing hormone in an attempt to increase the TSH also stimulates prolactin secretion. Pituitary stalk damage results in impaired dopamine flow. And then there is a phenomena of macroprolactinemia, where the prolactin is increased, but it's mostly non-functional prolactin immunoglobulin complexes. So it's almost like a false increase, and then the lab can perform a precipitation step to remove the macroprolactin and see what the monomeric prolactin concentration is. Next, I've included the thyroid function test. So there was an interesting article from Dr. Helena Oosthuizen talking about navigating challenges of hypothyroidism management. And I thought it was a nice summary to explain how hypothyroidism can cause infertility. So in women, it results in anovulation and polymenorrhea, so the shortened menstrual cycles. In men, it can result in erectile dysfunction, low sperm count, and reduced sperm quality. And hyperthyroidism can also affect fertility. So the international guidelines recommend screening for thyroid disorders in all pregnant women at risk or women who want to fall pregnant, and the TSH level should be optimized before conception. So once again, the TSH and thyroxine levels can assist in determining whether the problem is at a thyroid level or if the problem is in the pituitary, in which case the TSH concentration will be decreased together with 3T4. I've included this table just to demonstrate that, especially for thyroid function tests, the levels don't always fall within the reference range. Something that we see quite often is subclinical hypothyroidism, where the TSH will be high and the thyroxine concentration will be normal. And usually antibody determination is recommended, your anti-thyroid peroxidase antibody, as well as your anti-thyroglobulin antibodies. And patients can be started on treatment if a certain criteria is present. For example, if the patient is antibody positive or risk factors like type 2 diabetes or dyslipidemia is present. Otherwise, these patients can just be followed up annually. Something else to note is sick thyroid. So ideally, when the patient is acutely ill, thyroid function testing should not be performed, as it can affect the levels and can create confusion. But typically what we see in the so-called sick thyroid syndrome is a normal TSH with a low FT4, although if it's severe, both the TSH, FT4 as well as the FT3 can be decreased. Next, we'll look at dehydroepiandrosterone sulfate. DHEAS is only produced in the adrenal glands. So when the concentration is increased, it suggests adrenal origin, such as an adrenal tumor. The clinical utility is in the differential diagnosis of hyperandrogenism, as well as an adjunct in the diagnosis of congenital adrenal hyperplasia, although it's not the primary tool to diagnose congenital adrenal hyperplasia, and also in the diagnosis and differential diagnosis of premature adrenocele. So that's a benign pubertal variant where your LH, FSH, testosterone, and estradiol will be normal, and only your DHEAS will be increased. I've included this picture because when the DHEAS concentration is increased, it is important to exclude exogenous use of DHEA preparations, and this can be in postmenopausal females where vaginal suppositories are available to treat vaginal atrophy, as well as DHEA treatment in fertility. So DHEA increases testosterone, which is important in the early stages of follicle development, and treatment can be used in especially older patients. Androstenedione originates from the adrenals and from the ovaries. It's the major precursor for testosterone and estrone, and it's elevated in cases of hirsutism as well as virilization. So just to remind us, hirsutism is when there's excess terminal body hair in a male distribution pattern. So that would be the chin, lip, the areola, as well as the back and the abdomen. So in a female patient with virilization and increased androstenedione, the presence of a normal DHEAS suggests ovarian androgen. So if the patient had increased DHEAS as well as an increased androstenedione, it indicates an adrenal producing tumor rather. Just some analytical considerations. Androstenedione does exhibit diurnal variation, so levels are highest in the morning, and there's also cyclical variation where levels are highest mid-cycle because the follicle secretes androstenedione. Levels can also be increased during pregnancy and following exercise, and falsely increased in patients on androcur treatment. 17-hydroxyprogesterone is produced mainly by the adrenal glands. It's increased in congenital adrenal hyperplasia. Classic congenital adrenal hyperplasia is due to 21-hydroxylase deficiency and presents early in life as ambiguous genitalia in females or virilization. It can also cause salt wasting. Non-classical congenital adrenal hyperplasia presents later in life. The presentation is not as severe because these patients do have functioning enzyme activity, although it's decreased, so they don't present with ambiguous genitalia or salt wasting. But adolescent females as well as adult females can present with features of hyperandrogenism, which includes hirsutism, oligomenorrhea, and acne. Beta-ACG is released by the trophoblast cells during pregnancy. These cells form the outer layer of the developing blastocyst following conception and implantation. Beta-ACG stimulates progesterone production of the corpus luteum, and the main action is to maintain the corpus luteum during pregnancy. Levels are usually detectable 3 days after implantation of the embryo, which is about 6 to 12 days after ovulation. So levels will be detected earlier in blood compared to over-the-counter urine test. During a normal pregnancy, levels usually double every 2 days and then plateau and will decrease again at 8 to 10 weeks. So decreasing values may indicate threatening miscarriage or an ectopic pregnancy. Also important to note with regards to beta-ACG is that perimenopausal or postmenopausal women can secrete pituitary ACG, which can cause a bit of a diagnostic confusion, but usually the levels are only slightly increased, and when in doubt, the FSH concentration can be measured, and if it's increased, it is consistent with menopause. Alternatively, these patients can be started on hormone replacement therapy for 2 weeks, and then the LH, FSH, as well as the ACG concentration will decrease. The clinical utility of beta-ACG. So apart from detection and monitoring of pregnancy, it's also used in Down syndrome screening to evaluate risk and also to detect and monitor ACG-producing tumors. Next, we have anti-Mullerian hormone. Anti-Mullerian hormone plays an important role in the development and growth of ovarian follicles. The concentration is usually in the upper range of normal or increased in patients with PCOS. AMH is used to assess ovarian reserve in women and also to predict response to controlled ovarian stimulation. So it has a good specificity for predicting poor response in IVF cycles. AMH in general is highest after puberty and then decreases progressively with age and is usually undetectable at menopause. And it's also relatively stable during the menstrual cycle. So you can measure it any time during the cycle with limited variation. And just to note, patients on oral contraceptives can have decreased AMH levels. Here we have a report example and the suggestive cutoff values. As we can see, values greater than 16.4 picomoles per liter is associated with a high or excessive response. And this becomes important because of the risk of ovarian hyperstimulation syndrome. But in general, AMH level, as we can see there, the comment states, can be used as a predictor of ovarian response following ovarian stimulation during IVF treatment, but should always be used in combination with clinical and ultrasound findings. Just to note, apart from AMH, there are other tests of ovarian reserve, which I won't go through in detail, but one of them is cycle day 3 FSH, which should be low. So day 3 FSH as well as estradiol should be low. The other test of ovarian reserve is the clomiphene citrate challenge test. So clomiphene usually results in increased FSH and LH secretion, which should stimulate the ovarian follicle and increase your estradiol concentration. If, however, the pool of follicles is reduced, then there's insufficient production of estradiol, and there won't be a negative feedback on FSH. So a normal response would be for the FSH to decrease. However, if there's poor ovarian reserve, then you don't have that decrease in your FSH concentration. Okay, so looking at clinical conditions, this table summarizes recommended hormone tests in general practice. So for each condition, which test should be requested. Also, to make it easier, AMPATH has certain hormone profiles available. So if you choose the hirsutism profile, for example, it would include those hormones, infertility profiles, as well as menopause profiles. Okay. So I'm just going to briefly go through each profile. I've included polycystic ovary syndrome under the hirsutism profile because it's a similar workup. So with regards to polycystic ovary syndrome, there's the Rotterdam criteria available, and 2 out of 3 should be present for the diagnosis to be made. The first one is hyperandrogenism. Secondly, irregular menstrual cycles, and thirdly, polycystic ovaries on ultrasound. So there is a specific criteria for the polycystic ovary. So, for example, there should be 12 or more follicles, 2 to 9 millimeters in diameter. And also to note is that other conditions that mimic PCOS should be excluded. And this includes non-classical CAH, which can be excluded with 17-hydroxyprogesterone levels, which is usually less than 6 nanomoles per liter, can exclude the diagnosis. Cushing's syndrome can be excluded by doing a 24-hour urinary cortisol, salivary cortisol, or a dexamethasone suppression test. And then androgen secreting tumors, where the DHEAS concentration can be done. With regards to the pathophysiology behind PCOS, there are a few suggested hypotheses. One of them is abnormal gonadotropin secretory dynamics, and there's increase in LH levels, LH pulse frequency and amplitude, and this is where the LH to FSH ratio comes into play. Another theory is in utero exposure to androgens in a female fetus can result in LH excess and features of PCOS to develop at puberty. There's also a bit of a chicken and egg situation between hyperinsulinemia and hyperandrogenism, but hyperinsulinemia can also contribute to hyperandrogenism by stimulating androgen biosynthesis in the ovary and also by decreasing sex hormone binding globulin production in the liver. We put a lot of emphasis on PCOS as well because there is a risk of cardiovascular disease. A large majority of patients are obese or overweight. There's also the risk of developing type 2 diabetes, fatty liver, and non-alcoholic steatohepatitis and obstructive sleep apnea. PCOS can definitely affect fertility, resulting in anovulatory cycles. And because of the chronic stimulation by estrogen in the presence of the low progesterone associated with the anovulation, these patients are also at increased risk of endometrial cancer, and in general it can impair the quality of life and result in mood disorders. So this is the suggested laboratory investigations, and then I've also included the summary of why each test should be performed. As mentioned, 2 out of 3 criteria should be present. And then always in a patient with amenorrhea, oligomenorrhea, pregnancy should be excluded. TSH can be performed to rule out hyper and hypothyroidism. Prolactin performed to rule out hyperprolactinemia. We've mentioned the non-classical congenital adrenal hyperplasia, as well as the adrenal neoplasm and Cushing's syndrome, which can present similarly. And then the LH and FSH ratio, although it's not part of the criteria, it can be used, and a ratio of 2:1 is regarded as the cutoff. And then other tests to consider because of the metabolic profile is a fasting lipogram and the oral glucose tolerance test. A lot of these patients are already started on estrogen, progestin, oral contraceptives to manage the symptoms. And it's just important to note that these preparations can falsely decrease your FSH, LH, and testosterone concentration. So the recommendation is to stop the medication for at least 4 to 6 weeks before measuring the androgens. And then also patients on metformin or spironolactone because of their symptoms. The medication should also be discontinued before doing the laboratory investigations. And the LH-FSH ratio can be misleading in certain conditions. For example, if there's been recent ovulation, LH can be suppressed and then the ratio will be lower than 2:1. So that's also something to keep in mind. Here we have an example of a laboratory report for a 29-year-old female with suspected PCOS. What we can see here is the LH and FSH. In this case, the ratio is greater than 2:1. The anti-Mullerian hormone concentration is increased. And these patients have increased AMH because of the increased number of their preantral or small antral follicles. And these follicles are also in early stages of development, which results in an increased AMH concentration. For this specific patient, the prolactin concentration is normal and the free testosterone calculation is increased. Looking at male infertility, so the majority of causes are testicular, either congenital or acquired. Acquired causes can be infection, drugs, radiation, exposure to toxins, metals, smoking, hypothermia, etc. And then about 10% of causes can be attributed to endocrine or systemic disorders that will affect your testosterone or sperm production. In a small majority of patients, no identifiable cause can be found. And the aim of the laboratory investigation is to identify males where the cause can be treated to restore normal fertility. Looking at expected patterns, so for primary hypergonadotropic hypergonadism, the testosterone concentration will be low with a high FSH and LH. And for secondary hypergonadotropic hypergonadism, the testosterone concentration will be low with an inappropriately low or normal FSH and LH. So the normal response should be for the FSH and LH to increase. Further investigations that can be performed include iron studies, prolactin, cortisol, and thyroid function. And if these are normal, then brain imaging can be performed. And just note, if the problem is mainly in the seminiferous tubules, then only the FSH will be increased. And if there's androgen resistance, only the LH will be increased. And if everything is normal, depending on the findings, and semen analysis can also be performed. Then looking at female infertility, about 25% is due to ovulatory disorders. Here the lab can play a role, for example, in identifying luteal phase defects where there's inadequate production of progesterone. Other causes include hyperprolactinemia, and then there are a few anatomical abnormalities that can result in female infertility, which we won't go through in detail for this talk. Female infertility should be investigated after 1 year of regular unprotected intercourse in women younger than 35 years, or 6 months of unprotected intercourse in women older than 35 years. The laboratory assessment of ovulation includes a mid-luteal phase progesterone level and a value of greater than 9.5 nanomoles per liter is suggestive of recent ovulation. Although, as we saw in the previous table, and some references will refer to a value of 30 nanomoles per liter to indicate ovulation. And then over-the-counter urinary ovulation prediction kits detects the LH surge to predict ovulation. If the progesterone concentration is less than 9.5 nanomoles per liter, or if the patient has a very irregular cycle, then further testing as well as a PCOS assessment should be performed. So here we have an example of an infertility profile for a female. So in this case, if the patient is in the luteal phase, this progesterone is very low, so it may suggest an ovulation. Then lastly, just to mention menopause. So the diagnosis is mostly clinical and based upon the presence of irregular menses or menopausal symptoms in a patient older than 45 years of age. The amenorrhea should be present for at least 12 months. And in a patient in late reproductive years, pregnancy should always be excluded, especially in a woman who's not on reliable contraception, who's sexually active. And the role of the lab is in supportive criteria. So due to the low estradiol, sorry for that spelling error, FSH will be increased, and then the AMH concentration will be decreased. Inhibin will also be decreased, although inhibin levels are not routinely performed. If the patient is on an oral contraceptive, it should be discontinued, and the FSH should be measured 2 to 4 weeks later. With regards to menopause, there's also a transition period between the age of 40 and 45 years. So these patients will still have irregular menstrual cycle, endocrine changes, and typical symptoms like hot flushes, sleep disturbance, or sexual dysfunction. And there's also early menopause or primary or premature ovarian insufficiency with exactly the same symptoms, but in a patient that's younger than 40 years. And in both cases, the FSH concentration can be misleading, especially in your premature ovarian insufficiency patients, where they can still intermittently produce estrogen and ovulate and even fall pregnant. But during the normal ovulatory cycles, FSH will be within the normal concentration. However, during the amenorrheic periods, the FSH can be in the postmenopausal range. But it is suggested to do the FSH on day 3 of the cycle, where day 1 is day 1 of a normal menstrual flow. And also just to note that hot flushes aren't always due to menopause, and it's important to also consider other causes like Carcinoid syndrome and pheochromocytoma. Here we have a laboratory report of a 48-year-old female who had a menopause screen performed, and these values are not in keeping with menopause, so she might just still be within a normal follicular phase. Next, we have a 46-year-old female with hot flushes. The estradiol, FSH, and LH is within the postmenopausal range. And just a note on pregnancy, there are a lot of physiological and hormonal changes that take place during pregnancy, and the placenta itself can produce multiple steroid hormones, estrogens, progesterone, and placental lactogen, and this will affect various metabolic and endocrine systems, and especially there will be increased thyroid binding globulin, increased sex hormone binding globulin, and many of the laboratory reference intervals for non-pregnant patients are not appropriate for pregnant patients. And that's why it's important to note whether the patient is pregnant or not on the request form, and then the appropriate reference ranges can be provided. Then lastly, I just want to mention the effect of exogenous hormones on laboratory parameters. Patients on oral contraceptives containing ethinyl estradiol does not cross-react in the immunoassay that performed within the laboratory. So this means that because of the exogenous estradiol, endogenous estradiol will be decreased. So the normal measurement of estradiol will be decreased, and your LH and FSH will also be decreased because of the negative feedback because of the exogenous estradiol. Oral contraceptives will also decrease your androgen production because they inhibit the hypothalamic pituitary ovarian axis. So your free testosterone as well as your total testosterone will be decreased. And then ethinyl estradiol can also result in high sex hormone binding globulin, which will also affect your levels when measured, which will be increased. This was a nice review looking at all laboratory parameters that can be affected if you are interested in further reading on this subject. Here we have an example of a 44-year-old female on oral contraceptive. The laboratory will provide the expected ranges. So the normal response to oral contraceptive is for your endogenous estradiol to decrease, and as well as your FSH and LH concentration to also decrease. When we look at anabolic steroid use, patients don't always volunteer the information, but clues can be a muscular phenotype with testicular atrophy and oligospermia that is present. Some patients may even develop gynecomastia. Typical laboratory findings. So when a product is used that cross-reacts with the testosterone assay, it will be detected within the assay, and the testosterone concentration will be increased, and your LH and FSH concentration will be decreased. When the patient discontinues the testosterone, then your endogenous testosterone will be decreased, as well as your LH and FSH, and it can take a few months up to a year for the levels to normalize. Other abnormalities that can be noted is hypercholesterolemia with increased LDL and triglycerides and low HDL, and these patients can be polycythemic, and these patients can also develop abnormal liver enzymes. When a product is used that does not cross-react with an assay, then it won't be picked up by the assay, and the testosterone, LH, and FSH concentration will be decreased. Patients on hormonal therapy, for example, hormone replacement therapy for menopause, either for vasomotor symptoms or for the genitourinary syndromes, there are different estrogen preparations available: oral, transdermal, gels, lotions, intravaginal creams, and tablets. But they all have similar efficacy, but usually patients with symptoms like hot flushes will be treated with a systemic estrogen, while patients with genitourinary symptoms will be treated with a local estrogen. But to note here is that 17-beta estradiol will be picked up on the laboratory assay, and also some patients are started on progesterone if they still have a uterus because of the risk of endometrial hyperplasia and cancer. Hormone therapy for testosterone. So testosterone therapy is also available in different forms: topical, intramuscular, and oral preparations. Intramuscular injections are the most popular, and they result in a gradual release from the oil-based vehicle in which they are administered. So they result in a a prolonged presence of testosterone in the blood. So usually the dosage is only once or twice weekly. The oral preparations have a lot of hepatic side effects. So patients on testosterone therapy should be monitored to determine that the testosterone concentration is within the normal range. The timing is very important, and the testosterone should be measured midway between injections, 2 to 3 months after initiation of treatment and after changing a dose, and thereafter, when the patient is on a stable dose, they can be monitored every 6 to 12 months. If the patient is on treatment for primary hypogonadism, then LH determination can also be done. In a question we often get asked, are results from different laboratories comparable? So different methods to measure hormones have differences in standardization. So this makes it difficult to compare results from different laboratories. Results should ideally be performed by the same laboratory using the same method, and method-specific reference ranges should be used. Also, if there's a method change or an assay is updated, it can also affect the results and their comparability. So when, for example, LH and FSH is measured and it's within a reference range, and that's different when, for example, comparing an increasing beta-ACG. Then it can be confusing if the value is decreased, but the test was performed in a different laboratory using a different method. So ideally, the follow-up should be performed by the same laboratory or at least the same method. Then I just want to end off with 2 clinical cases. I see we still have a few minutes left. So the first clinical case, I didn't have the history, so we can, the scenario could be a 37-year-old patient presenting with fatigue and decreased libido, or it could be a patient presenting with infertility. What we can see here is that a proper fertility workup was performed, but the only abnormality was decreased total and free testosterone. So I found this algorithm on UpToDate, so I thought we can use it to try and determine a cause in this patient. So this is a young patient. Ideally, testosterone should be performed early morning and the low level should be confirmed with a second repeat. In this case, let's assume this was repeated and the low value was confirmed. This patient has a normal LH and FSH, so if you follow this algorithm, this suggests secondary hypogonadism. So the next step would be to rule out other causes such as hyperprolactinemia, hypercortisolism, and for example, iron overload disorders. And all the investigations were normal in this case. So the next step would be to image the brain to look for a hypothalamic or pituitary cause for the secondary hypogonadism. Assuming the MRI scan was normal, it is important to further ask the patient about exogenous testosterone use. These laboratory results can be in keeping with a patient who recently discontinued exogenous testosterone treatment, and there hasn't been time yet for the hypothalamic pituitary axis to normalize. So furthermore, if this patient has a semen analysis and oligo or azoospermia is present, this can be in keeping with a patient who recently discontinued exogenous testosterone use. The next case is from a case I saw in the Clinical Chemistry Journal, where it's a 34-year-old female referred to the endocrinologist for evaluation of secondary amenorrhea, hirsutism, and possible PCOS. There's no clitoromegaly, acne, or deepening of voice, which is against the diagnosis of an androgen-secreting tumor. She was prescribed spironolactone and metformin by the GP. So remember, treatment should be discontinued before doing a hormonal assessment. The patient also had resistance to weight loss efforts despite diet and exercise. So already our differential diagnosis can include type 2 diabetes, non-classical CAH, and then because the patient had a round face, increased BMI and truncal obesity, it's also important to exclude Cushing syndrome. So here we have our laboratory results. The ACTH and cortisol was normal. 17-hydroxyprogesterone was slightly increased. DHEAS was normal. Prolactin, FSH, and LH was normal. 17-beta estradiol was normal. Then the total testosterone and the free testosterone was increased. So I just converted the units from nanograms per deciliter to nanomoles per liter. So this patient has a total testosterone of 11 nanomoles per liter, and we said a value of greater than 9 nanomoles per liter is suggestive of an androgen secreting tumor. And furthermore, this patient had an ACG performed to exclude pregnancy. So in any patient with secondary amenorrhea, pregnancy should be excluded. Furthermore, in this patient, her HbA1c was normal, and if we do suspect Cushing syndrome, we can do the late night salivary cortisol, 24-hour urinary cortisol, or overnight dexamethasone suppression test. So the next step in this patient was to perform let me just go to the next slide, an ultrasound. So we've already mentioned most of this. So pregnancy was excluded because it's the most common cause of secondary amenorrhea. And then after pregnancy was excluded, we should always measure the FSH, TSH, prolactin, and free thyroxine to exclude other causes. And in this case, all the investigations were normal. And the next step can be to do an progesterone withdrawal test. And in this patient, we're not concerned about primary amenorrhea and outer tract obstruction, but assuming that a withdrawal bleed is present, we can measure the androgens. So in this patient, the testosterone was increased. So we are looking for either an androgen-producing tumor, or we are looking at adrenal hyperplasia because of that 17-hydroxyprogesterone that is slightly increased. So usually we look at a cutoff of around 6 nanomoles per liter. So in this patient, it was 8.6 nanomoles per liter. But the pelvic ultrasound found a 12 centimeter adnexal mass. So in the end, this patient had an androgen-producing ovarian tumor. And the urine steroid profiling in the urine showed that the 17-hydroxyprogesterone was from an ovarian origin and not from a adrenal origin. Okay, so thank